Good evening, ma'am.
Good evening.
Am I audible?
Yeah, but I think volume is problem with me. I will rejoin. There is some problem with the volume.
Good evening, sir.
Good evening.
Hello,
Yes, ma'am.
am I audible?
Yes, ma'am.
Okay, start.
Okay. Good evening, everyone. I'm continuing the lecture of the hematoma that we have left behind the last time. I'm continuing with the neurofibroma. Neurofibroma is the benign tumor that arising from the connective tissue of a nerve that containing the ectodermal, neural, and the mesodermal connective tissue component. It is the autosomal dominant disease that involves the epineurium and the perineum and the perineum is spared. It can be single or multiple.
So usually it is in the course of now.
Yes,
Most of the time it is in the course of the now. When it is superficial, it is usually in the course of the now and it is a subcutaneous tissue, neurofibroma. But if it is into the retroperitoneum, then it give rise to a very large size and then it is named differently, right? Continue.
Okay. The sites of the neurofibroma are the cranial, spinal, and peripheral. Neurofibroma are the most common intradural extramedullary tumor of the spinal cords. The types of the neurofibroma, they are either localized, generalized, plexiform, elephantitic, cutaneous. Localized neurofibroma most commonly involves the peripheral nerve. There are smooth, rounded, firm, and encapsulated margin. They mostly they move in the horizontal direction or the perpendicular to the direction of the nerve. The pain in the hyperesthesia is only present in the distribution of the nerve sites. This is the neurofibroma. Other type is the.
See, all the time it do not look like this. What you are showing neurofibroma, it do not look like this. Sometimes it is in the subcutaneous tissue also. This is a skin neurofibroma. See, in this you will find out swelling like this. But if it is in the subcutaneous tissue, it will be just like lipoma, but it is firm in consistency.
Yes.
Okay. Continue.
Another type is the generalized neurofibroma. It is the variant of the neurofibromatosis type 1. It is the autosomal dominant disease, which is present in the 1 in the 3. The ratio is 1:3000. Most commonly present into the male patients. It occurs due to the mutation into the chromosome number 17 in the long arm of the chromosome number 17. It is mostly this is an image showing there is a generalized neurofibroma with the cafe-led spots in the skin. The characteristic of this cafe-led spots from the other diseases like McElbride syndrome is that it is mostly more than 5 in number with more than 1.5 in centimeter, which involves the which are neuroectodermal in origin of nerve sheath cells and the melanocytes. In this neurofibromatosis type 1 it also represents with the axillary freckles. The axillary freckles that are the small coffee color spots that are present into the skin that I have shown in these pictures. The another characteristic is the list nodules. There are coffee color uh, nodules that are present in the iris, which is seen in the slit lamp examination of the patient. Other
So, most important point in this generalized neurofibromatosis, and these patients do not present early. And then they come at the elderly age group when one of the neurofibroma becomes malignant. So when patient comes to you for the surgery for some specific neurofibroma, it is particularly, it is more commonly into this spinal and paraspinal region. And there is, it is when they come to you for the complications like that, they are not able to sleep because of the large size of neurofibroma in the back. So don't take patient immediately for the surgery, particularly when it is in the back. And those patients should be considered for the MRIs just to see that extension of this neurofibroma into the spinal canal. Right. So sometimes because of the chronicity, overlying whatever body may have thinned out, or at the exit of the nerve there may be thinning. And so once you excise this, then patient may have some neurological problem. Or patient, it turned out to be a neurofibrosarcoma. So before that, patient requires proper investigation. Right? Continue.
Another type is the plexiform neurofibroma. Usually it occurs in the area of distribution of the trigeminal nerve, and there is a thickening of the skin. Due to that, the skin hang downwards and it also causes the erosion into the bone orbit and the other deeper structures. This is the figure that there is a involvement of the face, there is back and the groin region. There is a thickening of the skin with the edema, so the skin will be hang down. Usually patient present with the pain and the paresthesia over the site of the distribution.
So how will you differentiate it from the lymphedema? So usually it is congenital, but slowly and progressively it is increasing. That is one thing. And sometimes there is a little bit pigmentation is found as compared to lymphedema. There is no pigmentation. Here little bit pigmentation you will find at the fold, whatever the folds are there at that site you may find out sometimes pigmentation. Okay. Most of the time it do not require surgery, but when it is obstructing the vision, or it gives rise to, because of the hangings, give rise to some decubitus ulcers, then it requires surgery. Okay.
Another important thing is it involves one of the dermatomes. So in lymphedema, you have uniform swelling or ununiform, but swelling of the whole limb or of that thing, whereas in plexiform, one particular dermatome, the whole limb will not be enlarged, but as you can see, there will be folds,
yes,
huge folds. Go ahead.
Yes, sir. Pachydermatosis. This is the variant of the plexiform neurofibroma, where it only involves the area of the distribution of trigeminal nerve. As the figure showing the ocular part of the trigeminal nerve, there is the fold is covering the left side of the eye of the patient. The elephantiatic neurofibromatosis. It is the severe form of the plexiform neurofibroma. It is the rare, mostly involves the lower limb. The skin of this.
So elephantiatic word is usually used when it is involving the lower limb.
Lower.
Mostly, yeah.
The cutaneous variant of the neurofibroma, which involves the terminal ends of the peripheral cutaneous nerve, which are multiple small pedunculated cutaneous nodules, which involves the mostly involve the chest, abdomen, and the back region. Sometimes it may be present on the forehead and the scalp, which is also known as the turban tumor.
But you should have taken a better photograph of the turban tumor rather than this. See, Lobelli has given very excellent photograph of turbine tumor. So you will never forget turbine tumor. So in exam, it is asked that how will you differentiate turbine tumor from this lindroma? So you have to differentiate these two things. Okay.
Schwannoma, this arises from the Schwann cells that are single or multiple fusiform, form soft, lobulated, and well encapsulated tumor with the whitish gray in the appearance. They usually displays the origin of the that nerve. So the and it will be present with the pain and paresthesia along the distribution of the nerve. So yes, this tumor displaces the nerve. The treatment of this phenomena will be excision.
The nerve, it displaces the nerve. So when it is a nerve sheath tumor. It is also known as a neurolimoma, right? So when you find out this type of small nodule, particularly near the face or the mental region, which will affect the cosmesis. So in that case, if you get the FNSE and they give the report of schwannoma, then you will not operate immediately, right? So it gives rise to scars. So you will just follow up such patients, particularly in cosmetic area. Okay.
The other complications of the neurofibroma are the cystic degenerations. There is a hemorrhages into soft and deeper tissues with muscular atrophy. The neural and the spinal tumor in the spine and neural component. There may be chances of the compression of the neural elements. So neurological deficient may be present, and sometimes there may be secondaries. The patient may develop the sarcoma. So at this time the surgery may be required.
Yes.
Thank you. Ma'am, the next lecture will be presented by the Shaket and Anik on the cascade pathway.
Okay.
Good evening, ma'am. I'm Anik Rathi. I'll be presenting this presentation on coagulation cascade along with Saket, who will be discussing the second half of the presentation. Now, coagulation and hemostasis. First of all, what is the need for it? Normal hemostasis it comprises of a series of regulated processes that maintain blood in a fluid clot-free state, such that the blood does not clot on itself in the blood vessels, while also rapidly forming local hemostatic plugs at places where there might be vascular injuries. And as is hemostasis, the pathological counterpart would be thrombosis, which is the formation of blood clots, which is needed at the sites of injury. Now, the components of coagulation include basically have three elements. First of all, the blood vessel wall. The second one would be the platelets, and the third one would be the coagulation cascade in itself. The blood vessels have endothelial cells within them, which on getting injured release endothelin, and also due to neural stimulation reflexes, they go into transient vasoconstriction, which for the time being tries to control the bleeding. And the second element, which is primary hemostasis, takes into action the help of platelets, such that they aggregate and form a platelet plug, which further accentuates the action of the endothelial vasoconstriction. The last final plug is formed by secondary hemostasis, which would be the main array of this presentation, which is done by various coagulation factors. Now, the first response to injury. Yeah, again, it is basically due to the injury to the endothelial cells, which causes activation of platelets and coagulation factors due to some.
See, before that, I will ask you if patient is having arterial injury and venous injury. So what will be about this first two and the last, what you say? What is the difference in this both? Go back.
Yes.
So there is a endothelial response and primary hemostasis, right?
Yes, ma'am.
So what is the difference in hemostasis when there is arterial injury, and what is the difference there is a venous injury?
Ma'am, in an arterial injury, the main hemostasis would be maintained by platelets, whereas in a venous injury, the blood flow would be stopped due to the coagulation cascade, the secondary hemostasis.
Yes, because of the high pressure, systolic and diastolic pressure into the artery, vessel can go into the spasm. And
Yes,
so because of this spasm, as you say, there will be a vasoconstriction of the vessel. Because the more muscles are present there, the vasoconstriction is possible. As compared to into the vein, the muscles are less comparatively because it requires blood to return back to the heart. And so muscles are less. So pressure is also less. And so this spasm, vasoconstriction will be less when there is a venous bleeding.
Yes,
so previously in Law Bailey, they have written that is my teacher went for a coffee after cutting the renal artery. See, you can cut the renal artery and apply the mop and then ask the assistant to keep pressure and can go for coffee. But after cutting the vein, he cannot go for coffee, right? Like this. Okay.
So the first response to injury, as soon as the endothelial membrane is breached, the endothelial cells, they release certain factors which causes activation of platelets and the other coagulation factors, which are termed as procoagulants. And also the loss of endothelial integrity causes exposure of von Willebrand factor on the basement membrane, which further causes adhesion of platelets to the basement membrane of the blood vessels. The second element which comes into play is the primary hemostasis, which is done by the platelets, namely platelet adhesion, activation, and aggregation. Platelet adhesion is the main function of von Willebrand's factor. The platelets have glycoproteins GP1B, which bind to von Willebrand's factor on the extracellular membranes. Now, as soon as adhesion takes place, it leads to platelet activation, which further is associated with the release of various granules, namely alpha granules in this case, which includes calcium and adenosine diphosphates, which are further mediators for the platelet adhesion and aggregations. Also, as the platelets bind to each other, that is, they aggregate, there are changes in the shape and the membrane compositions, which causes activation of GP2B3A receptors, which are basically for interlinking of the platelets to each other. They help in forming cross links with each other as well as with fibrinogen. Now, this forms the primary hemostasis. The primary.
Go back. You have not completed. Go back. What happens when there is activation of the receptor?
Ma'am, as the GP2B3A receptors are activated, it forms crosslinks with each other, with fibrinogen as well as with the platelets, which leads to the third step. In platelet adhesion, activation, and aggregation, GP2B3A is needed for aggregation, and these.
So that will activate the thrombin. That will activate the thrombin. That is important.
Okay, it activates thrombin, which further converts fibrinogen to fibrin in the final plug.
Yes.
Now, yes, ma'am. Now this forms the temporary plug, the primary hemostasis. It is unstable. It can bleed. It can get easily dislodged if there is any major movement. This has to be strengthened, and that is the function of the third part, the coagulation cascade, which forms a fibrin meshwork, strengthening the platelet plug. Now, this is a series of amplifying enzymatic reactions such that the proenzyme is converted to enzymes, and they further keep going through the cascade. These are namely the coagulation factors, out of which 13 there are multiple coagulation factors, out of which 13 are of major significance. Now,
So this is important when this thing happens, when first year resident is attending the casualty and he says that there is a spotter or there is a big hematoma. See, repeatedly you should not explore patient into the casualty. So in that case, you consider that what is the problem, and you have to take patient directly to the OT and explore there with the presence of the anesthetist. So if required, you can operate under the anesthesia also, right?
Yes,
So
ma'am.
don't explore the wound repeatedly when it is bleeding. Otherwise, all these factors are lost and all this system is lost.
Yes,
Okay.
ma'am. Now, once the primary plug is formed, the coagulation cascade begins. Now, in this case, the endothelial cells release various factors which causes release of these coagulation factors, which are basically proenzymes, which become active enzymes, and they further keep continuing this process until there is activation of thrombin. Now, thrombin, its main function is to convert fibrinogen into fibrin monomers that polymerize into an insoluble gel. Now, the most important part here is the insolubility. It forms a meshwork with the platelets and other circulating cells such that it will not get that easily dislodged as was the primary plug. And the last factor which would play an important role in this would be the factor 13A, which would cause the stabilization of fibrin by cross-linking them with each other. Now, for even that, thrombin would be needed for activation of factor 13 to factor 13A. Now, these are all the major 13 factors at a glance, of which factor 1 is fibrinogen, which forms the main plug at the end after getting converted into fibrin by thrombin. Now, factor 2 is prothrombin, which is converted into thrombin by the action of factor 10 Stewart power factor. Now, the process of formation of the secondary hemostatic plug, it can be due to extrinsic or intrinsic pathways which converge at the activation of factor 10. Now, the extrinsic pathway is the most physiologically relevant pathway. Signed out. Sign out हो गया.
Continue, you are audible.
Hello. Yes, ma'am. Sorry, ma'am. The extrinsic pathway is the most physiologically relevant pathway for coagulation. Now, the main difference between the extrinsic and the intrinsic pathway is how they begin. The extrinsic pathway, it is due to tissue injury, which releases tissue thromboplastin, which causes the activation of factor 7, which directly activates factor 10. It is a shorter pathway as compared to the intrinsic pathway. And the intrinsic pathway is basically, it is more involved in the lab settings, where we have to perform various tests to check for the various coagulation factors, as it can be activated by putting the blood on. One example would be glass slides. Glass is also an activator of intrinsic pathway in cases of coagulation. Then the laboratory tests. These are of major significance for us, as we constantly use them in our clinical settings. Now, prothrombin time, it screens for the activity of the proteins in the extrinsic pathway, that is, which was activated by tissue injury, factor 7, which activates factor 10, then thrombin, factor 5, and then directly fibrinogen. It is the shorter pathway. Now, since factor 7 is the vitamin K dependent coagulation factor, therefore it also has a very short half-life. So prothrombin time is used to guide the treatment of patients with vitamin K antagonists. So, for example, warfarin. as we use it for the management of various clinical vignettes such as in DVT. The second test which we use is partial thromboplastin time, PTT, which screens for the activity of proteins in the intrinsic pathway. Now PTT is sensitive to the anticoagulant effects of heparin and is therefore used to monitor its efficacy. Heparin acts as a thrombin inhibitor, and its action is checked by PTT. Thrombin time, it directly shows us how if there is any abnormality in the conversion of fibrinogen to fibrin, which is the last step in the secondary hemostasis. Now, since heparin is a thrombin inhibitor, therefore thrombin time increases in patients receiving heparin injection.
So whenever your patient is coming with this DVT on warfarin, PT is required. But if patient is on heparin or LMWH, we are not doing PTT routinely or APTT routinely. So in that case, INR we should be checked, right?
Okay, ma'am.
Okay.
Now, once coagulation has taken place, what would be the further steps to prevent that so that there is not
Another, pardon. Another one thing I forget. If patient is in the periphery, when patient is on heparin, fastest test is BTCT, bleeding time, clotting time with the capillaries.
Yes,
So
ma'am.
previously we were doing, you might have also learned in MBBS that you are sitting BTCT
Bleeding
with the
time and clotting
capillaries.
time.
So that will be also altered with the heparin, and you can immediately see in the ward on the table, on the cot by doing this. See, if some old examiner comes for exam, you should know that is also a test to know it immediately, right?
Yes.
Okay.
After coagulation pathway has been activated, it must be tightly restricted to the site of injury to prevent inappropriate and potentially dangerous clotting elsewhere. Now, besides restricting the factor activations to the sites exposed, as in endothelin and the coagulation factors, there are various mechanisms within the human body, such as there are antithrombins which inhibit the activity of thrombin and other serine proteases. Now, antithrombin 3 is activated by heparin-like molecules as heparin and LMWH and fondaparinux, which does not let thrombin convert fibrinogen into fibrin, thus preventing the formation of the secondary hemostatic plug. Now, then secondly, there is protein C and protein S, which are both vitamin K dependent proteins that act in a complex to proteolytically inactivate cofactors 5A and 8A respectively. Protein 5 factors 5A and 8A both. Protein S acts as a cofactor in the activation of protein C. Then the third method used by the body is the tissue factor pathway inhibitor, which is a protein secreted by the endothelium that inactivates factor 10A directly and tissue factor 7A complexes.
So in a patient who is having bleeding diathesis and you investigate that patient and you find out patient is not having factor VIII deficiency, right? So still you think it is a congenital, nowadays protein C and protein S is done and treatment remains same. You have to consider those patients having hemophilia and like that treated as in the follow-up also as a hemophilia, and you have to give factor VIII in that patient after calculation. Okay.
Okay. Now, controlling coagulation, there are basically two cascades: procoagulants and anticoagulants. Anticoagulants, as I just discussed, would be protein C and protein S, which causes activation of which causes inactivation of factor 5A and 8A. And the second one would be plasminogen, which converting into plasmin by tissue plasmin activator TPA, which causes fibrinolysis, that is the cleavage of the fibrin mesh. And a procoagulant would be vitamin K, which causes which is used by the liver to cause gamma carboxylation of coagulation factors 2, 7, 9, and 10, which are necessary for the coagulation pathway. Then the coagulation disorders, they can be either congenital or acquired. Congenital are due to lack of a component of the coagulation pathway, which these may or may not present until trauma or surgery in adulthood has been done. And also they depend on the quantitative lack of the factors. That is, if there, for example, in hemophilia A, there can be a mild disease, a moderate disease, or a severe disease, depending on the percentage of factor rate as compared to normal. 2 to 50% would be a moderate hemophilia, and less than 2% would be severe hemophilia. Now, severe hemophilia can present with spontaneous bleeding, in the form of hemarthrosis, whereas mild hemophilia may not present until late adulthood, when the patient might suffer any trauma. And another form of hemophilia is hemophilia B, the deficiency of factor 9. Then there can be von Willebrand's disease due to deficiency of von Willebrand factor that was necessary for platelet adhesion in the formation of the primary hemostatic plug. Other two syndromes which are associated with platelet dysfunction are Bernard-Soulier and Glanzmann's thromboasthenia. Bernard-Soulier does not let the platelets bind to the endothelin receptors, whereas Glanzmann's thromboasthenia prevents the aggregation and adhesion of the platelets to each other. All of these may present according to the varied quantitative levels in the body. Then there can be acquired disorders, which can be due to various array of reasons, such as there may be lack of synthesis of factors, such as in liver disease, in cases of malabsorption and various infections, when there might be vitamin K deficiency, leading to decreased coagulation factors 2, 7, 9, and 10. There may be increased consumption of factors as in DIC or massive blood transfusions, or in autoimmune diseases such as systemic lupus erythematosus or rheumatoid arthritis.
How there is increased consumption? Tell me. In DIC?
Well, in DIC, there it leads to, in
What is
DIC,
the full form of DIC?
disseminated in intravascular coagulation.
Yes. So there
There
is,
are
you don't know in which vessel there is a coagulation. So
yes.
it may be coagulating at so many vessels. So the patient is unconscious or semi-conscious or drowsy. So you don't realize where is the coagulation has occurred into the limb, in the intra-abdominal part,
Yes,
into the
in
muscular
DIC,
part.
the basic.
In the pulmonary vessel. So in that case, clotting factors are utilized. So that is the loss of factors is because of it is utilized, just like in DVT also. In septicemia, septicemia, it is because of the destruction of the cells and the platelets. And in massive blood transfusion, whenever blood transfusion is given to the persons, the platelet destroys within 48 hours. It reduces by 50% in 24 hours, destroys by 48 hours. So platelet level will be very less. So in that case, whenever you're doing blood transfusion, massive blood transfusion, platelet is deficit. So you have to replace the platelet in that case, right? Okay.
This table very well describes how the various disorders of coagulation would present. As in the hemophilias would present with a fall in APTT, as factors 8 is basically a member of the intrinsic pathway. Von Willebrand disease also increase in APTT because von Willebrand's factor is necessary for the activation of factor 8. In liver diseases, both PTINR and APTT is increased due to decrease in the formation of thrombin factor 2, which is a vitamin K dependent factor. Similarly, in vitamin K deficiency, both PTINR as well as APTT are increased. In massive transfusion, as ma'am said, platelet count decreases severely due to massive blood transfusion. But here the fibrinogen degradation products are normal, whereas it helps to differentiate it as compared to DIC, where the FDP would be raised in cases of DIC. And in heparin we use APTT to monitor the action of heparin, whereas PT-INR is used basically for warfarin. The further presentation would be continued by my colleague Saket. Thank you, ma'am.
Good.
Good evening, ma'am. Good evening, sir. My name is
Good evening.
Saket. Coming back to the coagulation pathway, I would like to discuss on the various drugs which act on different pathways in coagulation pathway. So let's talk about the factor 10A and factor 2A. Both of them are basically in the combined pathway of the coagulation factors. Both heparin and low molecular weight heparin acts on it, but heparin has more efficacy over the 2A factor rather than 10A. So anticoagulants which are inhibiting factor 2A are heparin, low molecular weight heparin, which includes enoxaparin and dalteparin, and direct thrombin inhibitors, which are the novel anticoagulants, namely argatroban, viabilidin, and dabigatran. Factor 10A inhibitors are again low molecular weight heparin over heparin. Direct 10A inhibitors, the novel anticoagulants, which are apixaban and rivaroxaban, and fondaparinux. Other drugs are thrombolytics, which inhibits the which actually acts on the plasminogen and makes more plasmin so that there will be thrombolysis of the formed clot. Another drug which I would like to discuss on is tranexamic acid, which is antifibrinolytic, which is a competitive inhibitor of lysine residue over plasminogen. These are the antiplatelets which I would like to discuss in a very short manner. GP2B3A, the factor which is important for aggregation of multiple platelets with fibrin in it, is inhibited by abciximab, apitifiban, and tirofiban. On the same classification, ADP receptor inhibitors are clopidogrel, prasugrel, and ticlopidin, and COX inhibitors, which inhibit the arachidonic acid conversion.
How many days before the surgery you will stop clopidogrel?
Yes, ma'am. I wanted to discuss it in the next slides, but clopidogrel.
Okay, then continue.
Yes, ma'am. This is the first drug which I would like to discuss on is heparin. Heparin acts on both thrombin and factor 10A, more over thrombin rather than factor 10A. It is a platform on which the inhibition occurs. It does not act on a receptor. It is a platform on which the thrombin and factor 10A resides on, and the activation of them is inhibited. Its clinical use is immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI, deep vein thrombosis, and it is used specifically in pregnancy because warfarin is contraindicated because warfarin is crossing placenta but not heparin. Follow APD.
So how will you give? I will repeat so many times.
Yeah.
How will you give this heparin in pulmonary embolism?
I would like to give it as a bolus dose of 5,000 international unit, followed by 25,000 international unit in one glass pint in NS in normal saline over 24 hours.
So 1,000 per hour, right? You can give by infusion pump also if patient is having pulmonary edema and you cannot give 2.5 liter of the fluid. So in that case, you can give 100 ml, 1,000 units by infusion pump also. So 1,000 units per hour. It should go like this for 24 hours. After that, it will be again 5,000 units subcutaneously 6 hourly. Okay.
The adverse effects of heparin are bleeding, thrombocytopenia, osteoporosis, drug-to-drug interaction because it is metabolized by CYP23A4, the enzyme cascade in liver. Its specific specific antidote is protamine sulfate.
How much will you give?
Unfortunately, I don't know the answer. Sorry, ma'am.
So it is 100 units. If you are giving 5,000 units, it requires 100 units. Okay.
Yes, the other similar drugs are low molecular weight heparin and fondaparinux, which I told are acting more on factor 10A rather than on thrombin, so they do not have more side effects as heparin. And heparin-induced thrombocytopenia is a major complication. And I would like to add on that if heparin-induced thrombocytopenia occurs, we would like to use other oral anticoagulants as its antidote. The next drugs are direct thrombin
But
inhibitors.
what is the advantage of giving LMWH over heparin?
Low molecular weight heparin has lesser side effects and it has lesser. It acts on factor 10A rather than factor 10A over thrombin. So the anticoagulation is, there is no thrombocytopenia, lesser drug-to-drug interaction, and uh, blood monitoring is not required in low molecular weight heparin.
Yes, that is important. It is having less effect on APTT. And so whenever you are giving LMWH, the side effect is less. And compliance is also good because heparin, if you are giving initially, it requires 1 hourly, then it requires every 6 hourly. So time, and here it requires only twice in a day. So compliance is also good. So time is very well managed for giving this drug, right? So this is the only the advantage, and cost wise heparin is cheaper as compared to LMWH, but the LMWH is given subcutaneously, and so sometimes it is also given if patient is at home, while heparin is to be always given into the hospital because it is not given subcutaneously nowadays as a routinely. Whenever it requires, it is given IV. Right, for first 24 hours. Okay.
So then what is the advantage of heparin then?
Sir, heparin will act rapidly. So in cases of emergencies, we would like to heparinize the patient. Low molecular weight heparin.
One thing. Secondly, short duration. So preoperatively, you can give heparin and stop it. In those patients, high cardiac risk patients who are on various other drugs, you can give heparin and stop one dose and then operate within 8 hours.
Even in pregnancy with diabetes. Yes, even with pregnancy, patient is having pregnancy and with DVT. In that case also patient is, if your patient is in full-term pregnancy, then patient should be admitted till patient is going for this labor pain. That is also recommended that in that case you have to switch over to the short-acting heparin if you are planning for the CS also. Okay.
The second class of drugs are direct thrombin inhibitors. Example, bivalirudin. They directly inhibits the activity of free and clot-associated thrombin. Clinical uses are similar to heparin, venous thromboembolism, atrial fibrillation. Most important uses heparin-induced thrombocytopenia. It does not require lab monitoring. Adverse effects are bleeding. Unfortunately, there is no reversal agent. If we want reversal, we can use prothrombin complex concentrates or fibrinolytics. Warfarin, it is the oral anticoagulant, acts by interferes with gamma carboxylation of vitamin K dependent clotting factors, factor 2, 7, 9, and 10, along with protein CNS. Unfortunately, this is the reason why why the concept of bridging therapy is coming here. Warfarin will cause procoagulation in its early effects because it will inhibit protein CNS initially rapidly rather than factor 2, 7, 9, and 10 because protein C and 7 has lesser half-life. Protein CNS are anticoagulants. If warfarin inhibits protein CNS, the anticoagulation component will be gone and initially warfarin will be procoagulant. So the bridging therapy comes here as we will start heparin along with warfarin and later we will decrease the dose and stop heparin after 3 days and we will continue oral anticoagulant to discharge the patient. Clinical uses chronic anticoagulation for venous thromboembolism prophylaxis, prevention of stroke and atrial fibrillation. It is unfortunately not used in pregnant women because it crosses placenta and it has teratogenic activity. Its adverse effect is bleeding, skin/tissue necrosis. Drug-to-drug interaction is similar to heparin because it is metabolized by liver. And skin tissue necrosis within first few days of large doses. due to small vessel microthrombosis, the concept of procoagulation. Heparin versus warfarin. Heparin is larger anionic polymer, whereas warfarin is small amphipathic molecule. Route of administration, heparin is intravenous, warfarin is oral. Site of action, heparin is in blood, warfarin is in liver, because it has effect on the gamma carboxylation in liver. So its antidote is vitamin K injection. Duration is heparin, just as sir told, shorter half-life and rapid onset of action, whereas warfarin, it takes days. Agents of reversal. Monitoring is APTT for heparin and INR specifically for warfarin. The other classes of drugs, direct factor 10A inhibitors, apixaban, rivaroxaban. It binds to and directly inhibits factor 10A. Treatment and prophylaxis for DVT and PE, pulmonary embolism, stroke prophylaxis, and atrial fibrillation. They are oral agents. Novel anticoagulants does not require coagulation monitoring. Adverse effects is bleeding. Unfortunately, there are no reversal agent available. Thrombolytics includes alteplase, reteplase, streptokinase, tenecteplase. Mechanism is directly or indirectly aids conversion of plasminogen to plasmin, which cleaves thrombin and fibrin clots. Increases PT-APTT, no change in platelet count. Clinical uses early MI, where percutaneous intervention by balloon angioplasty is not available. Early ischemic stroke, direct thrombolysis of severe pulmonary embolism. Adverse effects is bleeding, contraindicated in patients with active bleeding, history of intracranial bleeding, recent surgery, known bleeding diastasis, or severe hypertension. Toxicity is there is antidote, an inhibitor of fibrinolytics, whichever tranexamic acid or aminocaproic acid can be used. FFP or cryoprecipitates can also be used. These are some of the antiplatelets which I would like to touch on. ADP receptor inhibitors, as I mentioned on the chart, are clopidogrel, prasugrel, ticagrelol, and ticlopidem. Inhibits platelet aggregation by irreversible blocking of ADP receptors. Also prevents expression of glycoprotein 2B3A. Clinical uses acute coronary syndrome. It is used in coronary stenting. Some of the stents which are coated with antiplatelets, these are the drugs which they use. Adverse effects is neutropenia, specifically in ticlopidem, and thrombotic thrombocytopenia may be seen. Cilostazol and dipyridamole are specifically used in small vessel diseases. They act by phosphodiesterase 3 inhibition, increases CAMP in platelets, resulting in inhibition of platelet aggregation, acts as vasodilator. Use is in intermittent claudication, coronary vasodilation occurs, prevention of stroke or thromboischemic attacks. It is combined with aspirin and angina prophylaxis. Adverse effects is flushing, headache, nausea, hypotension, and abdominal pain. The newer drugs, glycoprotein 2B3A inhibitors, are abciximab, apitifibatide, daraxonrasib. One of them is monoclonal antibody. Mechanism is bind to glycoprotein receptor 2B3A on activated platelets, prevents aggregation. Abciximab is monoclonal antibody. Clinical uses unstable angina, percutaneous, transluminal, coronary angioplasty. Adverse effects is bleeding, thrombocytopenia. The other antiplatelet drugs are yes, sir.
Wait. Last slide. What? Go back. Yeah. Regarding ADP receptor inhibitors, what is, and the glycoprotein, what is the duration of action? Any idea? Because it's an irreversible blocking of ADP receptor. That's why I'm asking.
Yes, sir. It acts for 7 to 9. The half-life is 7 to 9 days because platelets will be recycled after 7 to 9 days.
Yeah, so very long acting, right? Okay.
Yes, sir. So as ma'am asked, we will have to stop clopidogrel before 5 days of any elective surgery. I will
Minimum, yeah. Yeah. Continue.
Yes. So the aspirin. It is non-steroidal anti-inflammatory drugs that irreversibly inhibits cyclooxygenase, both COX-1 and COX-2 by covalent acetylation. It inhibits synthesis of thromboxane A2 and prostaglandins. So it increases bleeding time. No effect on PT and APTT because it does not have effect on any coagulation pathway. So effect lasts until new platelets are produced. Clinical use is low dose aspirin for inhibition of platelet clinical use will be dependent on how much dose of aspirin we will give. Low dose will inhibit platelet aggregation. Intermediate dose will act as antipyretic and analgesic, and high dose will act as anti-inflammatory. Unfortunately, these high doses will cause renal damage, so we are not using it clinically. Adverse effects are gastric ulceration, tinnitus.
See, for this analgesic effect, this cardiologists say that if you are having aspirin, so then you take 300 milligram aspirin, dissolve it into the water and take immediately, because most of the time when they develop MI, they are not having handy any other analgesic. And so they advise that you take as an analgesic also, right? Okay.
Adverse effects are gastric ulceration, tinnitus. Chronic use can lead to acute renal failure, interstitial nephritis, GI bleeding. Risk of Ray's syndrome in children. It mimics it happens post-viral infection in children. Causes respiratory alkalosis. Transitions to mixed metabolic acidosis. It has dual effect. It causes respiratory alkalosis initially, and later it causes metabolic acidosis by effect on kidney. Celecoxib is
What dose? What dose?
Sorry, sir.
We don't use it in that dose now. Already Madam has said.
Yes.
We use 75 or 150 milligram, which does not create much of an issue. Most of the patients are taking 75 milligrams.
Yes.
So maintenance dose is 75 milligram when they are having global ischemia or repeated attacks of angina. At that time it is given. In surgery we use only 75 milligram.
Celecoxib is reversible inhibitor, specifically acting on cyclooxygenase 2. So the side effects of aspirin won't be seen in this drug. Which the COX-2 isoform is found in inflammatory cells and vascular endothelium, mediates inflammation and pain, spares COX-1, which helps maintain gastric mucosa, thus does not have corrosive effects of other NSAIDs on GI line, spares platelet function, because thromboxane A2 production is dependent on COX-1, which is not inhibited by Celecoxib. Clinical uses rheumatoid arthritis, osteoarthritis. Adverse effect is increased risk of thrombosis because it does not act on COX-1. Sulfa allergy is another side effect. Other NSAIDs are ibuprofen, naproxen, indomethacin, ketorolac, diclofenac, meloxicam, piroxicam. All are reversible inhibitor of both COX-1 and COX-2. They are non-specific inhibitors. They block prostaglandin synthesis as well. So they are used as antipyretic, analgesic, anti-inflammatory. Indomethacin may be used for patent ductus arteriosum in pediatric patients, and ibuprofen, naproxen in females. Adverse effects is interstitial nephritis, gastric ulcer, renal ischemia.
And nowadays it is used for this chikungunya. Naproxen is used for chikungunya.
Yeah, very good.
Yeah.
I would like to summarize all the drugs. Vitamin K antagonist is warfarin. Direct thrombin inhibitors. Oral is dabigatran. It's dabigatran has an antidote. It is idarucizumab. IDARICUZUMAB.
What is the dose? Dabigatran.
Dabigatran is
just now in COVID it is used as 110. 110 OD. Okay.
The parenteral direct thrombin inhibitors are argatroban, lapirudin, and bivalirudin. Indirect thrombin inhibitors are low molecular weight heparin, fondaparinux, and direct oral 10A factor inhibitors. The oral novel anticoagulants are rivaroxaban, apixaban, edoxaban. The half-life of all the drugs which are clinically important. Platelets are 7 to 9 days. The antiplatelets, ecton platelets, so 7 to 9 days will be the function of antiplatelet drugs. Heparin acts for only 2 hours, as mentioned by sir. So it is acting and it is of short duration. Warfarin will take about 2 to 3 days. So bridging therapy will come in place. NSAIDs 24 to 40, the specific COX-2 inhibitors. According to subtypes, it will be 24 to 48 hours. Surgical aspects. When to stop oral anticoagulants? There are multiple debates over it. The minor procedures, which are upper gastrointestinal scopies, where no no other intervention is there. We it's not really required to stop oral anticoagulants in minor procedures. Unfortunately, we will have to stop the oral anticoagulants 2 to 3 days before elective surgeries. And if the surgery is in emergency, vitamin K and fresh frozen plasma is required to reverse the effect. Immediate post-op heparin might be required in cases of valvular disease patients, atrial fibrillation, patient having mechanical valves, and deep venous thrombosis or pulmonary embolism. This is the NICE guidelines. It depends on the patient, if the patient is high risk, moderate risk, or standard risk. In which patients are we supposed to keep the coagulants and antiplatelets continued is dependent on this. So high risk patients, example, NSTEMI or STEMI episode for less than 1 year, cardiac drug eluting stent given less than 1 year, elective cardiac stents, carotid surgeries, stroke, visceral arterial stents, we might have to defer the surgery, or we will have to continue all the antiplatelets and take the high risk consent. In all of the patient.
So we will get the patients with incisional hernia after CABG. So keep in mind that they are high risk patients. So after CABG, if they develop incisional hernia, we will not operate for 1 year. As such, 6 months is for the incisional hernia, but in CABG, you can wait up to the 1 year if it is a small hernia. Okay.
In moderate risk patients where the procedures of cardiac stenting is greater than 1 year, or in STEMI episode greater than 1 year, we would stop clopidogrel.
So high more than 1 year. Any high more than 1 year.
Yes. Yes.
So gallstone, if patient is incidentally diagnosis of gallstone, so don't go for surgery. Call patient every 3 months and get USG and then operate after 1 year. Because sometimes for the abdominal pain, they have investigated and then our patient came for cholecystectomy for the gallstone and you find out patient is having ejection fraction 20%. You send patient for CABG and then don't operate immediately. Operate after 1 year, you follow up the patient.
Yes.
Okay.
So in those patients, we would like to stop clopidogrel about 8 days before the surgery and start on low dose aspirin, 75 mg. And in standard patients where there are low or no risk related to cardiac surgeries, we would like to stop clopidogrel as usual and continue aspirin. I would like to conclude the lecture after this.
Very good.
Yeah, good. Yeah, I'm really happy. Very good discussion. I hope the goodness in your lecture is referred to all the students. You need to understand this lecture. It will be of great help, I suppose.
Thank you, sir.
Good preparation and good presentation. Yeah, will you? Thank you, ma'am.
Okay.
Yeah,